is Allie. I am a hospice nurse. I've been a hospice nurse for over 5 years now. If you haven't been to my channel, then that's who I am. So today's video is going to be on families, the families of hospice, how to help them cope, different situations and scenarios that I think we all face and bump into, and how to handle those appropriately. Of course, I'm going to always put a disclaimer, do as your company says, don't always do what I say, but I think it is good to kind of look at different viewpoints of how people handle things. So if you have any questions or comments below, or you have any situations with families in particular that you would like to share, let me know. My eyebrows kind of made them a little bit big today, but enjoy me and my eyebrows. So did you hear my throat make that noise? Side note, yes, I am in my bathroom today, this moment. This video will probably be filmed in a variety of different locations. This is the bathroom. Towels. We have a lot of towels and my little one's bath toys. It is what it be. And my blepharitis is kicking up, as you can see why I look like Quasimodo. And my eyebrows look a little bit like caterpillars today. I hope you enjoy them. Yes. So the first thing we're going to discuss is families and the use of comfort kits, in particular morphine. I know we have a lot of families who are resistant to utilizing or initiating morphine. I understand that. Morphine is a scary word. It is a big, heavy hitter med. We need to emphasize to them that we are giving such small doses and that they are appropriate for the patient, and that we're not going to initiate morphine for no reason. We just don't start it just because they're on hospice. We initiate it only when it is needed, and we're going to be giving those in appropriate doses and frequencies. We are not giving them enough that will overdose them, but just enough to keep them comfortable. Education, re-education, super important in regards to comfort meds, pain management, and respiratory as well. The next issue we're going to address is families who don't think we're doing enough, or we don't think we're doing our job. Let's say, is the patient comfortable? If the patient looks comfortable clinically, you've done your assessment, we just have to re-educate them that this is what it's supposed to look like right now. We don't want to increase medications because there is no need to. We don't want to give them more than they need. If they're on a certain dose and a certain frequency and it seems to be working for them, then we want to keep them that way. We don't want to increase medications and possibly sedate them more than we need to. We never want to over sedate. That would be something that I would emphasize with the families. Of course, I would call not only my clinical manager, but I would probably also contact our hospice physician. They are a great resource when you're out in the field, especially if you need backup with some of our families who don't think necessarily what we're telling them is correct, even though these are the appropriate nursing interventions that we're using. Yeah, it's always good to get an MD backup. And I've had MDs even talk to the families on the phone before just to comfort them a little bit. It is a group effort. And I know our MDs don't have usually any problem pitching in to help out the cause. It's exactly what I would do. As long as in my heart I know that the patient is comfortable and there's not something that I missed. I did a thorough assessment, a good head to toe, would not beat myself up about it. Sometimes families just may not fully understand the process, and that's why we're there to comfort them. And like I've always said, educate and re-educate. Signs and symptoms of end of life. We don't need to give them more medications than they need. If it's not necessary, we don't need to give it. Just because someone's on hospice doesn't mean they need heavy doses of comfort meds. So yes, different place, different day. Next one we're going to talk about in regards to families is families who aren't comfortable with hospice care. Let's say there's a healthcare proxy who signed them on, but there are other family members who don't agree with it. And that does happen with siblings. Some people don't like the word hospice and they still are kind of stuck on the stigmas behind it. And we can only do so much to keep them comfortable. At the end of the day, our job is to keep the patient comfortable. And the family does matter too, but again, we can't always be so focused on how everybody feels, because our energy has to go towards taking care of our patient, who is our main priority. And you're not going to convince everybody that hospice is the right thing to do. You have to sometimes show them through our care that we're not here to hasten death. And that we're just there to provide comfort and provide the patient with the best quality of life. And that's all you can really do, because sometimes words aren't going to be enough. People have a certain, thought about what hospice is in their mind, and they're kind of stuck on it. So sometimes words aren't going to be enough to sway them. And in your mind, you also have to think that you might not be able to sway them on their opinion of hospice, but all you can do is do the best you can for your patient and make sure that the people who are there, like the healthcare proxy or the power of attorney, are educated on what's going on and you're keeping them up to date. That's all you can really do in those situations. Okay, so the next one is about our families who insist on having oxygen all the time, thinking that it will prolong life. Oxygen won't prolong life. It's just going to basically help the numbers that they're seeing. What we have to remind our families is that the numbers are supposed to go down at some point. So if our patient is having shortness of breath or, or normally is on oxygen, we're not going to take the oxygen away if that's something that they're used to having. But in regards to shortness of breath at end of life, opioids have actually shown to be more beneficial than oxygen. Supplemental oxygen won't hurt them, but it will not prolong life. There are patients who generally needed it before they started their end of life journey. So we're not going to take them off of the oxygen, but families are very focused on numbers, vital signs, pulse, O2 sats. We cannot stay so focused on numbers. We have to look at them through our assessment and see, does this look comfortable? We don't judge our patients' comfort based off of their numbers. We have to look at their breathing, grimacing, pain, down. Blood pressure, all that stuff. It's all going to go down. So, yeah, that's expected. Sorry I'm moving you so much. I have to hold my phone. Again, I kind of addressed this one before. The idea of families who get stuck on numbers, vital signs, what's their blood pressure, what's their pulse, what's their O2 sat. So we will take vital signs at every skilled visit. But when, like I said, when our patient starts transitioning or especially actively dying, those numbers really, I hate to say it, but they don't mean a lot. Unless we're looking for pain and that pulse is really up there. But again, we have some medications on board, such as atropine or Levsin, that might increase the heart rate anyway. So again, we're looking more at our physical appearance of our patient. Do they look comfortable? Breathing, facial expressions, grimacing, are they restless? Educate and educate and educate on those signs and symptoms of discomfort, pain, anxiety at end of life, so that they're aware that that's what we're going to be looking for, not so much like the oxygen saturation and pulse and blood pressure at end of life, because as indicated, those numbers will go down because we are expecting death. And this might not happen to everybody, but one thing I can tell, when a patient is really, really close, within minutes or maybe an hour of passing, that blood pressure is either super low. Automated cuff won't catch a blood pressure. Usually I'll be there for the patient's passing when that happens. It's really, I think, more of an anxiety thing to get families hooked on knowing numbers. But like I said, at each visit, I think it's okay to tell your patient if they want to know, or the patient's family if they want to know the vital signs. But when it comes down to it towards the end of life, we're going to be looking at, well, those numbers are going to decrease anyway, right? So let's not get hooked on them. Let's get hooked on focusing on how our patient is looking, how our family member is looking. Are we giving them closure? Are we giving them what they need at end of life, whether that's space or whether that's family members around them? Those, I thought I saw something. We need to fulfill those needs towards the end of life, which things like that might be the reason they're not passing away, why they're holding on. Holding hands is very important. Just reminding them of the things that they can do. I know families definitely want to find a way to be involved in patient care at end of life, just to feel like they have some sort of connection. You can totally do that. Give them advice on how to hand hold, or gently give hand massages, or apply lotion, mouth care, hair brushing, all the therapeutic interventions that they can actually implement that will make them feel closer to the patient. If they want to know the vital signs, they are more than welcome to know. But like I said, just remind them, don't get hooked on the numbers, because those numbers will be going down. And it might take away from your experience of being actually present with them in the moments before they're passing. Why is it AE lock? I don't know. I can't work cameras. So the next one is pretty common, I find, is a family, like the healthcare proxy or the power of attorney, not wanting the patient to know they're on hospice. Now, there are certain exceptions of this, like our confused patients and, dementia, Alzheimer's, because
what are they going to do with the information? It probably will just give them more anxiety. They might not clearly even understand what hospice is anyways. So when I approach my Alzheimer's patients, I usually just say I'm a visiting nurse, because saying I'm hospice might throw them into some sort of anxiety, panic-driven episode that we don't need, because they might not fully grasp the concept of what's going on. If your patient is any bit alert, of our admissions nurses sometimes have had the families mention before that when they've signed consents, before the family will kind of pull them aside and say, can you not mention the H word? It's kind of like right on the paper. I don't know how they go about dealing with that. But as far as if it's an alert and oriented patient and they don't know that they're on hospice, and your badge doesn't say that they're on hospice, but they ask, I wouldn't lie. That's what I tell the families. I say, I'm not going to lie, because I don't want to lie to my patients. Like I said, there are the exceptions of our confused patients, patients with other mental disabilities that may not fully grasp the concept, and it might end up hurting them more than anything. Just do your job as a hospice nurse, which up until the end is basically home health until they start being active or transitioning. Don't lie to your patients. Yes, there are exceptions. I find it very weird when alert and oriented patients aren't aware of their own goals of care. I understand that maybe for some people it might not provide them with the best quality of life towards end of life. It might give them more anxiety. It might not give them the most peaceful, feeling, knowing that they got diagnosed with a prognosis of 6 months or less. And if they ask, I can't lie. That's my take on it. The next situation, I have only gotten maybe a handful of times. Families who want to hasten death. Yeah, talk about a kind of awkward conversation to have. We cannot do that. It is not legal. It is kind of an awkward conversation to have. I really understand the families not wanting their loved one to suffer, especially those who are having a slow decline, like our Alzheimer's dementia patients. And it is hard to watch, and I really understand that. So all you can do is express your empathy and express how we're going to take care of the patient by providing them with comfort and quality of life whenever they decide to make that journey home. I would document it as, if you need to document it, I would document it as re-education on the goals of hospice or the plan of care, goals of care, whatever you want to put in it, if that is the way the conversation wants to go. And yes, yeah. I hope this was a little bit helpful in regards to how to deal with some of the more complicated family situations. It's going to be a lot of education. You have to remind them of the goals of care, right? We aren't looking towards curative. At comfort, we are looking at quality of life. Remind them that this is not about treating their disease. This is about treating the patient as a person. So we're going to be making sure they're comfortable. We're going to be making sure they're happy. Their mental health is great, and that they're generally just kind of at peace with everything that's going on. And that is our goal, is just to support the patient and to support the family through their journey. Where we think it's going to end as hospice, or whether or not they graduate, we'll be there either way. Educate, educate, educate. And remember to always document your education. It's kind of a pain in the butt, because as hospice, we do almost the same education at every single visit, because we have to remember our families have a lot going on. We have a lot of family members that are what we call the sandwich generation, which they have their own kids still to take care of. They have jobs, and now they're also caregivers for their parents. And that can be a lot. Financially, it can be very hard on them. Emotionally, mentally, it's very hard. They're providing their loved one with a really great gift, and that is to death with dignity. It's peace at the end of life, giving them a choice as to when they get to take their last breath and make their journey home. Seeing a loved one take their last breath, I think it would be a hard thing to go through. And, being the one who may be administering the medications all the time, having to make those calls as to when to give the PRN medications. Just remind yourself what they're going through. Yourself in their shoes. We may be looking at it as, well, they're being selfish, or they're not mindful of what the patient's going through. But I think that they themselves are going through a whole heck of a lot, emotionally, physically, mentally, all of that stuff. I think we need a reality check that a lot is on their shoulders. I remind my patients and their families, if you feel like you are second guessing yourself and you're not sure if what you're looking at is right, or if you're going to be doing the right thing, give us a call ASAP. That is why hospice is 24/7. But that's what we're here for. We don't want people kind of second guessing themselves and thinking, I'm not sure if I'm giving the right med. I'm not sure if what I'm seeing is discomfort, or if it's just restlessness, or if it's a mix of the both, or if it's all. We can't expect them to know all of this stuff because they've been taking care of their loved one for so long, but hospice is a new thing. It's a whole new journey of care. So let's try to be a little bit more supportive of our families, a little bit less judgmental. I mean, I understand some situations are very different. Situations can be uncomfortable for us as hospice because we know what we're doing is the best thing for our patients, but no matter what you do, you will probably always have a tough family member somewhere along the way that second guesses what you're doing. If you truly know in your heart that you're doing enough and your patient looks comfortable, then you've done your job. Be a better team, and remember, our families are part of our team now, and they're a very new member of our team. So we really have to support them and give them give them all the tools that they need so they can feel just a little bit more confident with being a caregiver during probably what is one of the toughest times they've ever had to experience in their lives. So that's my video for today on the families. I hope you guys enjoyed. Remember to give this video a like if you truly liked it. So yeah. And if you guys have any ideas for videos, comment them below. If you guys want, you can also follow me on Instagram. I do post there. I do like memes and stuff, but I also do educational stuff and some life stuff, mom stuff. Update me if you want on how COVID's looking in your area, how your hospice is handling the COVID. All very interesting to me. I know in my area, our cases seem to be going up. CDC as well, throwing us all for a loop that it is now airborne. Son of a bee, right? Anyone's policies changed because of that? I'd also like to know that. Subscribe, like, do all that good stuff that all those weird YouTubers say. And enjoy. Bye, guys.